Hello, my name is Robin Brown. I'm a core trainee and my research investigated the impact of frailty on trauma outcomes at a trauma unit. In the UK, frailty is increasingly being recognised by national trauma guidelines as a determinant of complex medical need. BOAST-1 guidelines now apply to all trauma with a frailty score more than 5, and the best practice tariff for major trauma centres stipulates the need for documented clinical frailty score in all patients over 65 with an injury severity score of more than 15. However, the current hip fracture best practice tariff is based purely on age, and despite a recent Bristol study demonstrating higher frailty in less severe injuries, the TARN best practice tariff currently only applies to MTCs in high severity injuries. With resources stretched, it's crucial that best practice tariff is played to benefit those that most require additional medical input. With increasing evidence of its influence on outcomes, does frailty have an impact as significant as age in those whose injuries are not severe enough to typically require major trauma centre input? The aim of this retrospective cohort study was to investigate whether degree of frailty has an independent effect to age on mortality and length of stay in patients with fragility fractures at a trauma unit, and thus whether it deserves greater recognition in future best practice tariffs. The admission notes of all patients aged 60 or over with a fragility fracture admitted to Gloucester Royal Hospital Regional Trauma Unit in 2019 were reviewed. A clinical frailty score was assigned retrospectively based on detail in the admission notes by one of 3 reviewers who had been familiarised with the Rockwood Clinical Frailty Scale. Length of stay and dates of death, where appropriate, were recorded using the hospital electronic database. 886 patients were included in mortality analysis, and 823 who survived to discharge were included in length of stay analysis. There was a wide range of clinical frailty scores recorded and wide age range throughout clinical frailty score categories. 30% were male and 74% were hip fractures. Each increase in clinical frailty score independently increased odds of death at 30 days by 55% and at 1 year by 56%, whilst increasing length of stay by 10%. Increase in age also had a smaller but significant independent increase in odds of death and length of stay. Interestingly, male gender increased odds of death by over 200% at 30 days and 1 year, whilst hip fracture increased length of stay by 30% without affecting mortality. Our data that clinical frailty score independently predicts mortality and length of stay supports other recently published research from our local major trauma centre, but demonstrates that this issue extends to trauma units and includes the hip fracture population. This therefore suggests that clinical frailty score should be included in the hip fracture best practice tariff, and for the major trauma best practice tariff to be expanded to include trauma units and those with lower severity injury scores in recognition of the high volume of vulnerable patients in this area. The study is limited by its retrospective method of clinical frailty score assignment by non-formally trained medical staff. However, clinical frailty scale score is widely praised for its usability with clear instructions, and group discussions facilitated robust scoring throughout. In summary, frailty is becoming increasingly recognised as a strong indicator of patient outcome. Our study shows its independent association with increased mortality and length of stay in less severely injured trauma patients than the current best practice tariffs currently account for. Future work should develop standardised systems to prospectively assign frailty scores to trauma patients at all hospitals and monitor outcomes to influence future resource provision in the form of best practice tariffs. Thank you very much.